So it's a very common topic in the era of COVID infection, and with the rapid rise of numbers of patients in the second wave, the world is again in the throes of pandemic. There is a devastating loss of human life, and this COVID infection has not only jeopardized our world's economy, it has also created disruption in our routine medical practice. However, a viral infection cannot cripple the operation of essential healthcare service. And echocardiography being an essential healthcare service, we need to provide safe and effective care for our cardiovascular patients. Needless to say that all necessary precautions and safety measures are to be provided to each and every member of the imaging team. If conducted in the usual way, which used to do in the pre-COVID era, echo is such a test or such an investigation where both the patient as well as the doctor or sonologist are exposed to a high risk of infection because of close proximity to the face with face-to-face contact. So, and COVID-19 being such contagious disease, this cannot be continued. So we have adopted certain temporary measures with a total paradigm shift the way we are doing echocardiography in the pre-COVID era and the post-COVID era. We need to protect the patient, we need to protect the doctor or the sonologist, as well as we need to protect the machine to prevent the transmission of infection. And by doing all these temporary protective measures, we are balancing ourselves with risk of infection by doing echocardiography to the inadequate patient's care by not doing echocardiography. No doubt we are facing challenges, constraints, but we know at the end of the day that it's the human spirit which prevails. So we are going to win the race. In the COVID era, we do the echocardiography for cardiovascular assessment of both non-COVID patient and COVID patient. COVID patients may be a suspected case, a confirmed case, or a recovering from the COVID infection. Whichever group the patient belongs to, the patient may be with or without pre-existing cardiovascular disease. We must remember that. And we face these patients while doing echocardiography in the echo lab, in the emergency room, in CCU, ITU, triage, ward, cath lab, as well as in the OT. But we must remember that a large number of patients of COVID infection remain asymptomatic, but still they transmit the virus to everybody. So that is why, irrespective of COVID status, COVID result status, all patients are to be considered as potentially positive while doing echocardiography. Now, in the initial phase of pandemic in the last year, echocardiography was done only in the urgent and emergent cases. We used to say it's essential imaging. All elective and non-essential imaging were deferred. And as a result of this essential imaging, cardiovascular imaging was reduced by around 50 to 90%. So over a period of last few months, it was found that this essential imaging has resulted in massive reduction in number, and which is very much detrimental. Also, a lot of financial implication is there. We are running loss of revenues. So over a period of this last 1 year, there is a change in concept. Now the concept is that we will try to keep the numbers same by creating an environment of lower infective risk. And this environment of lower infective risk means that we need to provide safety precautions to safeguard each and every member of imaging team, the patient, as well as the equipment. And in a country like India, that safety measures, we must remember that safety measures should be innovative, cost-effective, and less time-consuming, because we deal with a huge number of patients. While providing the safety measures, we must not forget about the vulnerable members of our imaging team. Those who are over 60 years, immunocompromised, comorbid, or pregnant ladies should avoid contact with suspected or confirmed cases of COVID-19 infection, because they are very prone to develop the infection as well as to develop the negative consequences of COVID-19 infection. That is why they should avoid the contact with COVID patients. Statements on the safety measures while doing echocardiography has been given by various societies and organizations all over the world, like American Society of Echocardiography, then Cardiological Society of India, American College of Cardiology, European Association of Cardiovascular Imaging. Now, we must not forget that situation is dynamic, so the recommendations also are subject to change. So for the equipment care is concerned to prevent the transmission of infection, it's very, very crucial. We should cover the machine and the probe with disposable transparent plastic sheets. We should wipe probe surface with sanitizer after each and every procedure. There should be dedicated machine for COVID positive ward or ITU. And at the end of the day, we should discard all the plastic covers, should wipe the external area of the machine from top to bottom with regular sanitizer, and also after every visit to ITU, CCU, triage, or cath lab and the OT. But we must not forget that this cleaning of the equipment depends on the institutional policy also. So it's adopted as per the institutional standards. Now, when we cover the machine with the plastic sheets, we face various challenges. Because of this cover, the movement of the trackball becomes a bit troublesome. And due to the cover on the probe surface, the image quality becomes suboptimal. So we must remember that with these covers, protective covers, we always balance between the benefit and compromises. Now, when the question of this benefit and compromise comes, now again, a very, very important thing to remember, the duration of scanning. See, our main goal is to limit the time of exposure to infection. So the duration of scanning should be very short. So there are certain measures which we can take to reduce the timing of the scanning, like we can check the medical records in advance. We can do the offline measurements. Nowadays, in all the machines, the facility is there. And we need to do limited and focused study with the diagnostic views. Like it should be like point of care ultrasound, mainly to see the systolic function of LV, RV, presence of thrombus, presence of signs of pulmonary thromboembolism or pericardial effusion. Again, though the procedure is quick, but we should not forget that we should not compromise with the accuracy, because otherwise we'll have to come back again to the patient for additional images. We should not compromise with the accuracy. And when all these questions of accuracy, quick procedure comes, now the question is, who will perform the scanning? We know that experienced echocardiographer can only do the quick procedure without compromising accuracy. Now again, the experienced echocardiographers often falls in this group, over 60 years, immunocompromised, comorbid, or maybe pregnant ladies. So ideally, A trained young cardiologist who is without comorbidity should do the echocardiography. The senior members of the echo team can always have a look at the recorded images. Now, while providing the precautions to the healthcare personnel, we know that there are two types of precautions. One is the droplet infection, another is airborne infection. Now, when we do the transthoracic echo or dobutamine stress echo in the echo lab or ward or in the emergency room, we need to provide droplet precaution. But the same procedure when done in the ITU, ICU, OT or cath lab where there is a environment of invasive ventilation. So in these areas, if we do transthoracic or dobutamine stress echo, we need to provide airborne precaution. And for transesophageal echo, it's always the airborne precaution. Now, we must remember that personal protection equipment depends on the institutional policy and resources. Some of the institutions divide the patients, provide the PPE depending on whether it's a non-suspected or minimal chance of infection or suspected infection or moderate chance, and the high risk means the confirmed cases. And some of the institutions, again, they treat the suspected and confirmed cases similarly. Now, in our lab and in our institutions, these are the protective, personal protective equipment which we use for droplet precaution. We wear gloves, sometimes if needed, double gloves, isolation gown, N95 mask, and surgical cap for echo lab and the ward. And we add double gloves, N95 plus surgical mask, face shield, and shoe cover for the airborne precaution when we do the transesophageal echo or transthoracic in the areas where there is a chance of invasive ventilation and aerosol producing procedures. Now the question is whether transesophageal echo can be done in the COVID era, because it is an aerosol generating procedure and there is a high risk of virus transmission and contamination. But we know that transesophageal echo is often reliable imaging in certain situations, especially in before the cardiovascular surgeries. So the present recommendation for transesophageal echo is that we should perform it if there is a favorable risk to benefit ratio. So the indication should be very proper. And our negative COVID-19 test result must be there within, which is done within 24 to 72 hours. And in the interim period, patient should be quarantined. But we must not forget that sensitivity of COVID test is only 80 to 85%. So we always should wear appropriate PPE during the transesophageal echo. And other than the basic protective measures like frequent meticulous hand washing, avoid close face-to-face contact with the patient, must wear a mask, and bare minimum number of personnel should be present. During transesophageal echo, this cannot be maintained. Patient cannot wear a mask. And we also need to sanitize the surrounding like patient's bed, desktop, chairs, phones, doorknobs, etc. So maintaining all these standards, now let us go to the common cardiovascular manifestations in the COVID-19 infection. Now initially it was thought that COVID-19 involves only the respiratory system, but over the last 1 year, we have noticed that its complications goes beyond lung, and it not only involves the heart, it also involves the kidney, brain, etc. Now, it can involve the heart directly or indirectly, causing acute myocarditis, acute pericarditis. Even there may be acute coronary syndrome, heart failure, pulmonary thromboembolism, different types of arrhythmias, and also we face sometimes the adverse cardiac effects of the medications. Now, we must remember that the patients with pre-existing cardiovascular disease are more prone to develop all these complications. And these complications may occur even without signs and symptoms of respiratory symptoms like running nose, fever, pneumonia, etc. So we should be very careful. Now, let us start with myocarditis. This is the commonest cardiovascular complication of COVID-19 infection, with the incidence varying between 7 to 28%. And it is a strong negative prognostic marker. Around 7% of COVID deaths are related to myocarditis. The signs usually appear 8 to 14 days after the onset of COVID symptom, and various mechanisms are said to be responsible for development of myocarditis. It might be a direct injury by binding of the virus to ACE2 and altering the signaling pathway of ACE2, causing the injury to the lung and the heart. Microvascular injury of the myocardial vasculature by microthrombi is another possibility. And cytokine storm and sympathetic surge during COVID infection may cause stress cardiomyopathy resulting in myocarditis, or it might be a case of acute coronary syndrome and MI, and also might be due to systemic hyperinflammatory response. Now, whatever may be the mechanism responsible for myocarditis, it is manifested by elevation of high sensitivity cardiac troponin. Let me show this case, who is a 60 years old male, had a history of hypertension and hyperlipidemia. He was complaining of chest discomfort for last 2 days. Typical cardiac type of chest discomfort for 2 days, but he didn't have a history of fever or respiratory symptoms. He never had exposure to COVID infection. And on examination, we found that patient was afebrile, ECG showed diffuse ST elevation, and cardiac enzyme was elevated. Chest X-ray was showing normal heart and the lungs. COVID test was sent, but we didn't receive the result. It was in the beginning of the pandemic last year. Patient was repeatedly complaining of chest discomfort, and echocardiography showed concentric LVH with global hypokinesia, ejection fraction of 30%. RV was dilated, hypokinetic free wall, valves were normal, but there was a small P. So clinically, and the diagnosis and also the ECG showed diffuse changes. So a diagnosis of STEMI was made. Though the COVID test was sent, but as it was in the beginning, so because the patient started complaining, the patient was taken for coronary angiogram, where we found that he was having a minor coronary artery disease. There was no obstructive lesion. And later on, COVID test turned out to be positive, and the repeat echo on 10th day showed that LV ejection fraction improved to 50% from 30%, and wall thickness also was reduced. Now, a similar case was reported in circulation, where chest pain with diffuse ST elevation was mimicking STEMI. So what the lesson we learned from this case? That COVID test is a must, even in absence of fever or respiratory system, even though patient complains of chest pain, because we expose the entire team to the COVID positive case without much precaution. And also we must remember that elevated troponin due to acute myocarditis in COVID-19 infection can mimic the STEMI. Now, if we learn this lesson and try to use this lesson learned in every case, we'll be in problem. Here is another patient who is 55 years old woman with hypertension, presented with history of shortness of breath, dull chest pain, fever for 10 days. She had passed few episodes of similar shortness of breath with dull chest pain in the past. And on examination, ECG was showing new onset LBBB, cardiac enzyme was elevated, and transthoracic echo showed LV systolic dysfunction with ejection fraction of 35%. And COVID test, this time we waited for the COVID result, and it was found to be positive. Now, how to proceed? We have learned that in a COVID patient, elevated cardiac enzyme with such vague history might be due to myocarditis, not due to STEMI. So now the question is whether we should proceed for coronary angiogram with additional risk of exposure to COVID-19 infection. But since the findings were suggestive and he gave similar history of chest pain in the past, we did the angiogram and it was found that the patient had 99% stenosis in the mid LAD. So again, we learn a lesson. A similar patient was also reported in JAC last year, where a misdiagnosis was done in a COVID-19 patient, though it was a true STEMI, but it was missed. So we learn again a lesson that when zebras are everywhere, we shouldn't forget the horses. So raised troponin is not always due to acute myocarditis in COVID patient. It might be due to ACS, which is an important cause of myocardial injury in COVID patient. The here is a patient. You see, this is the LAD area, which is akinetic, and epidemiologic studies have shown that viral infections, many viral infections, are associated with an increased risk of coronary events, including this the COVID-19 virus, because of the cytokine and inflammatory mediators. These substances can lead to the localized arterial inflammation of the coronary arteries. So the plaques, which were not limiting the flow in a normal condition in the same patient, can now produce ischemic injury because of this arterial inflammation. And we also know that in COVID-19 infection, there is a hypercoagulable state, abnormal activation of coagulation takes place, along with abnormal fibrinolytic system, and resulting in formation of thrombus. As you can see here, this was a patient who had a LAD infarction. Along with that, there is a large thrombus at the apex. Now, because of this abnormal activation of coagulation system, there's a chance of formation of thrombus in the veins, leading to a life-threatening complication in the COVID patients, that is pulmonary embolism. Now, this is the patients who present with pleuritic chest pain, shortness of breath with fall of BP, and the clinical deterioration results from the right-sided heart failure. And massive pulmonary thromboembolism may result in hemodynamic collapse, hypoxia, and death. Now, and that patient who presented to us with pulmonary thromboembolism, we got a dilated right ventricle. If you look at the RV free wall, it's showing akinesia, so systolic dysfunction. And normally, we know that RV is around 1/3 of the LV, whereas it is almost equal in size, maybe slightly larger than the LV. And normally, apex is formed by the LV, but in this case, both are taking part in formation of the apex. If you look at the IVS, it's flattened, LV function is preserved, and IVC was dilated. And a peripheral vascular Doppler showed multiple venous thrombus, and it's CT scan of the chest, which confirmed the diagnosis. Now, this type of RV dilatation with or without systolic dysfunction is seen in COVID patients with a high prevalence. The literatures have shown that in many cases, there is RV dilatation. And this finding of RV dilatation with or without systolic dysfunction is associated with early mortality, and it's independent of standard clinical biomarker risk stratification. Now, causes of this RV dilatation with or without systolic dysfunction might be other than pulmonary thromboembolism. It might be due to hypoxic pulmonary vasoconstriction, or ventilator-induced lung injury, or might be due to direct myocardial injury in the RV myocardium. Now, a multicenter prospective observational cohort study was conducted recently, which is going to be published in American Society of Echocardiography journal. This study was conducted in around 200 cases over the 18 years of age, and they followed up the case for 3 months. So what they found that in a large number of patients, there was RV abnormality, either in the form of dilatation with normal RV systolic function, or it might be a normal RV size with RV systolic dysfunction, or dilated RV with RV systolic dysfunction. And in follow-up, they found that no improvement took place in the patients who had normal-sized RV with RV systolic dysfunction. Whereas in the other two groups, there was a significant reduction in the number, so indicating that they had improvement in the RV systolic function. Now, because of this thrombus formation, we also may get in other cases because of this hypercoagulable state. Like one case was reported, one case of LV thrombus was reported in Takotsubo cardiomyopathy, and it came in Jack last year, who is a 74-year-old male, hypertensive, diabetic, dyslipidemic, presented with fever, shortness of breath, cough, chest pain for 5 days. COVID was positive. ECG showed ST elevation, which was suggestive of acute myocardial infarction. Cardiac enzymes were elevated. Coronary angiogram was normal. And look at the transthoracic echo. LV was dilated, showing akinesia of mid and the apical segments, whereas hyperkinesia of the base, which is a typical finding of Takotsubo cardiomyopathy. LV ejection fraction was 30%, and there were 2 large thrombi at the LV apex. Whereas echo on 14th day showed total resolution of the thrombi along with the improvement of the ejection fraction to 57%. Earlier it was 30%, and then on 14th day it went up to 57%. Pericardial involvement also occurs. Usually we get in many of the viral infections, but we get a very small pericardial effusion with benign course. And patient may present with chest pain. Only one case of cardiac tamponade was reported, which I am going to show. Usually we get a small pericardial effusion, see, anteriorly and posteriorly in the parasternal long axis, also all around the heart, and here this is the subcostal view, this is liver. A small pericardial effusion is present anterior to the RV as well as on the lateral aspect of the heart. Now, this case of pericardial effusion with tamponade was reported in Jack. This is the only case of large hemorrhagic PE was reported in a COVID patient who was 67 years old lady, a known case of non-ischemic cardiomyopathy with ejection fraction of 40%. She was not on antiplatelet or anticoagulant, no history of malignancy or coagulopathy. And then presented with mild cough, mild shortness of breath for last 3 days, chest X-ray was normal, COVID was positive, and transthoracic echo showed global hypokinesia with LV ejection fraction of 40%, but no pericardial effusion. Then patient suddenly deteriorated after 1 week. She had orthopnea, and then on physical examination, heart rate was high, 122 beats per minute. Respiration rate was 24 per minute, and the heart sounds were distant. Chest X-ray showed cardiomegaly. Enzymes were normal. And transthoracic echo this time showed a large pericardial effusion all around the heart with signs of impending cardiac tamponade, and ejection fraction was 40%. There was no RWMA, and IVC was dilated but collapsing. So pericardiocentesis was done, and it yielded around 800 ml of exudative bloody fluid. So this was the only case of large hemorrhagic pericardial effusion with tamponade which was reported. Many cases presented with cardiogenic shock, as Dr. Deepanjan has already shown nicely all the cases, even in this which were rescued by ECMO throughout the world, and a very good number of cases improved in Calcutta also. Dr. Deepanjan and his team did a fantastic job, so I'm not going to explain that. And this patient, which was reported, was 38 years old, diabetic, history of cough, shortness of breath for 2 days. And chest X-ray, there was pulmonary opacity, COVID was positive. Transthoracic echo initially was normal with no RWM, ejection fraction 60%. Then patient suddenly had SVT and deteriorated, had a cardiac arrest, and repeat echo now showing ejection fraction of only 20 to 25%. RV was normal in size, and but then there was reduced systolic function. This patient was rescued with ECMO. So in short, these are the common cardiovascular manifestations of COVID-19 infection. And I have shown you how crucial echocardiography is in identifying all these complications. So we are struggling, we are getting challenged while fighting with the battle, fighting the battle with COVID-19 infection. But we have realized how important echocardiography is in identifying these complications, also in taking the decision regarding the management. So it's a challenge for the imaging team, and we should never lower our guard while doing echocardiography, because high chance of getting the infection as we work face to face. And also during TE, there is an aerosol generation. So we should always adhere to the best protective protocols while doing echo in the echo lab or in the ICU, ITU, triage, and especially while doing transesophageal echocardiography, because it is an aerosol generating procedure. Thank you.